Excuse me if I cough at you, everyone. Okay, well, thank you very much. Welcome, everyone. We're still admitting people, but let's get going. Thanks, everyone, for being here. So to you, the usual. I'm Councillor Lucia Dusneves, and I'm the Chair of the Health and Wellbeing Board, and welcome to this meeting of the Health and Wellbeing Board. Please note that this meeting is being recorded for live and subsequent broadcast via the Council internet site. Please note that the meeting will be proceeding informally since we don't have, I'm not in the room and we don't have quite the right number in present physically. So welcome everyone, welcome to all our officers and everyone from across Haringey. But I think we have some apologies. I think we've got apologies for lateness from Councillor Brevison, don't we, Naz? And do we have some other apologies?
We have apologies from Mr. David Archibald, Mr. Andy Donald and Councillor Mike Harcastle.
Thank you very much. And do we have any items of urgent business?
None reported.
Thank you. And do we have any declarations of interest? No? None that I can see. Let's move on. And do we have any deputations, questions, petitions? Naz?
None reported.
None. Thank you. Okay, so first let's have a look at the minutes of the meeting from the 26th of January. Are there any comments and matters of accuracy? No? Thank you. So we'll agree those minutes and take those as agreed. Now, so straight to our first item. We've got Community and Mental Health Services Review. And I think it's Mary and Joanne, is that right? So I'll hand over to you if that's okay.
Thank you so much. It's actually, I'm Jo Murphy. I'm the Programme Director for the Community and the Mental Health Services Review. And in fact, it's Alex Smith with me. Alex?
Okay, thank you.
Alex, did you want to just introduce yourself? And then if we could start, that'd be okay.
Absolutely.
I think Alex is there, but perhaps not. So Alex Smith is the Director of Transformation for the CCG. Would it be possible for someone to put the presentation up, or shall I just take it as read and sort of talk to it? What would you prefer?
I think it would be good to have it up if that's possible.
Is there someone who can put it up? Thank you. So just while we're looking for the presentation, just to remind people that actually this piece of work's been going on for about a year now. We started it towards the end of March last year, and it covers mental health and community services. What we're, and Alex has just texted me to say he's IT's crashed at the minute, but he will be joining us. What I'm going to try and do is take you through the process that we've gone to, and then probably concentrate a little bit towards the end on where we are now. I guess it's a bit of a spoiler alert, because what we had hoped to be able to talk to you about is what we would be expecting to see in terms of changes in Haringey for next year, so from April. We're not there yet, so I hope no one will be disappointed to hear that as we go through the presentation, but we are quite close and we'll be able to give you a bit of an update on where we are with the work. Thank you. So if I could go to the second slide, I think would be really helpful. So just to remind people, the slide that's headed up introduction and background, that when the CCG undertook this work, it was very mindful of the differences in terms of services being provided across the 5 NCL boroughs, and for obvious historic reasons they were somewhat different. So one of the things the CCG has been really keen to understand is what were those differences, and what did those differences mean. So it has commissioned 2 reviews that are running in parallel. If it were possible to move on to the next slide, that would be really helpful, but if not, that's perfect. That's absolutely perfect. So what we have set up in terms of the review is a 3-stage process. The first stage, as I said, was to really understand what was happening in terms of service delivery, and also to understand about populations and kind of population need, and particularly as we were kind of at that point coming out of COVID, to understand what implications COVID had on population health, so particularly on long COVID, but for mental health as well, because I think we were all very, very aware that that real challenges to mental health services in terms of particularly young people accessing services, but for whole groups of population we knew that there would be an impact. So we spent some time gathering that data, and we've published that into cases for change that are available on the CCG website for anyone who's kind of interested in the detail. From doing that piece of work, we then moved on to think about, well, what would services look like if we were to, what do we think are our core services that we would want to make sure that every single resident across North Central London who needed that particular service should get. So we spent time over the summer agreeing core service offers, and that we did in conjunction with some local people, our experts' experience for mental health, from local council representatives, from primary care, etc., from our providers, I should say, shouldn't forget them, because they were really important in that. So we came up with a series of core service offers for both mental health and community services, and we've run the 2 reviews exactly the same, so same process for both. So we did that over the summer, and we have got core service offers which we have circulated. We haven't finally signed them off because, as I say, we're thinking about what gets implemented, but we are certainly we've shared them quite widely. And then we moved into a phase which kind of started in about October last year. It got slightly held up for obvious reasons with the COVID wave over this Christmas and into the new year, but that was to really think about some of the financial and non-financial benefits associated with the core service offer, and some of the work to think about how we would fund it, fund the core service offer. So we've been doing that work for a couple of months now, and as I said at the start, we're getting to a point where we can we can start to really refine that and agree what needs to go into our contracts for next year. This slide just sets out some of the governance. Sets out some of the governance of the programme. So you can see 2 programme boards, various membership, and I know that there are people attending this meeting today who come to our programme boards, but you can also see some of the engagement that we've done, so a whole range of different approaches to make sure that we had very good user and resident views. And we also, one of the things that we did spend some time doing is understanding and looking at previous engagement work, and it, I guess, was no surprise that many of the things that people had said before continued to be said when we went out and talked to people again. So, you know, that was helpful in one way, but a bit kind of depressing and sad in the other, that we'd not made much progress on that. But it was useful in terms of really getting to understand what some of the things that people thought were most important. And you will have seen in the pack, and I'll talk about it in a minute, a little bit about what we've done with that information. So if I can have the next slide, that'd be handy. So I'm not going to dwell on this slide because you can read it at your leisure, but it just tells you some of the differences in terms of provision and access, spend, and feedback. You know, there are just some examples there, but in the case for change, there's many more examples. But it does provide a sort of a compelling case for change. I can move on to the next slide then, please. That's lovely. So as I said, we'd worked on our core service offers, and this tells you a little bit more about what's in the core service offers. So thinking about things like operating hours, how people access them, because that was one of the things that came out quite a lot in conversation, you know, direct referrals, how did you get referrals from your GP, etc., etc. So we thought a lot about that, and we thought about the workforce, because obviously that's one of the big challenges we've got. So what is it we need our workforce to be able to do, and who needs to deliver the service, and then thinking about where that service got delivered, and that's around about, you know, is it in person, is it virtual, is it in someone's house, etc., etc. So those are the sorts of things that are set out in the core service offer, and as I say, that is they're very similar for both community and mental health in terms of their format, not necessarily their content. If you've got, I'm just going to talk a little bit more about the core service offer. So you can see from this slide, you've got a kind of the core offer outlines the range of services that are available to people. This is the community set of services, so services for children and young people, working age adults and older people. For mental health, we have a separate or an additional category, which is young people, so 18 to 25, and we added that in because one of the areas of feedback that we got quite a lot when we were talking particularly to young people and families was around about kind of the challenge around transition, so moving from children to adult services, and how we need to improve on that. So we have specifically thought about services particularly around mental health, but it is quite relevant for community services as well. And then you can see in the middle about coordinating functions, so really thinking about access via central points of access, thinking about trusted assessors and not having to repeat information, because again that was something that came through very, very strongly from users when we spoke to them. You know, how many times have I had to say this? And then thinking about kind of case management, particularly again for people who have got quite complicated care needs. So that is a sort of a central spine of how services get delivered. And then you've just got examples of core service descriptions. And I just want to be really clear, these are very, very high level descriptions. They're not service specifications, because I know some people have assumed that they were service descriptions and they're not. They sit under service description, service specification, sorry, sits under this. This is a service description, and we've got, I think, about 50 or 60 service descriptions for community and a similar number for mental health. We can go on to the next slide, please. Sorry, I'm whizzing through. Again, it's a little bit about the core functions, and we've looked across NCL. These are available differently in the boroughs, but there is a view from the discussions that we had again with service users, but as part of developing the core service offer, about the need to have some really central points of kind of fixed points that would link together different service areas and support delivery, and, you know, in a sense help service users as they navigated or try to navigate different systems. So this is just here for information and to sort of really try to bring out what the core service offer looks like. If we can go on to the next slide, that's great, thank you. And here is just some of the things that we think are benefits. This is community services, and I'm sorry, it would have been a lot of slides if we put similar ones in for mental health as well. So this is just to kind of give you a flavour. You can see here are some of the things that we think delivering a core offer consistently will help us deliver. And I think the sorts of things I think I would want to really, really pull out in terms of underpinning core service offer is around about quality, and here I'm thinking about prevention and early intervention. It's again something that came through very, very strongly from people we spoke to, was around about making sure that services were proactive and preventative to try and stop people escalating into care, or supporting them at, you know, within their communities and not needing to continually have more and more support and service. So thinking about how to help people stay as active and self-reliant as possible. But that was equally true for mental health as well. So a really, really strong focus on the conversations that we had and the aspirations for the services. It's probably no surprise that when we did some financial modelling, that in terms of particularly the community spend, it was not based on need. I think we probably knew that, but the piece of work that we did show that, and there was quite a variety in terms of what was being spent per head of population in each of the boroughs. The spend on need for mental health was closer, but in community there was quite a variety. If I can move on to the next slide, please. Okay, so we've tried to capture here, and I've kind of been alluding to it as I've gone through, some of the some of the kind of really rich conversations that we had, and some of the themes that came through from our engagement events, and then we've tried to describe how we've responded to those. I mean, lots of comments on waiting times, as you'd expect, as a result, well, prior to the pandemic, but as a result of the pandemic. And you'll see some of the kind of things that the CCG has been doing in terms of investments to address some of those waiting times. Excuse me. We'd also talked about things about, as I said, about the proactive care, about transition planning, and about not repeating stories and histories as much as possible. And again, we've tried very hard to think about how we could deliver different models to kind of respond to those issues raised. I suppose I just, for pulling it out here, we just wanted to say that, you know, we were really trying to really trying to listen and hear for what people had said, and then think about how that then got incorporated into the core service offer. Sorry,
I was just going to come in, Joe, just because normally we ask questions at the end, but I wanted to just come in because I think it might be helpful while we've got this slide up, because you've summarised some of the core feedback and how it's helped shape. But I just wanted a bit of narrative and just to talk a little bit with you about that, and just talk about, if you tell me, paint the picture for us. I know we've got the bullet points, but in your words, just paint that picture of what people were saying and how and what that's meant for how you're responding, if that makes sense a little bit, because I would think that a lot of people would be very interested in that. And I know you've got the bullet points and what have you, but it'd be really interesting to just talk a little bit about that and understand how that's translating into people's experiences, and then what your ambition is for how that will look different, you know, and how that has affected the thinking.
Yeah, I mean, I was expecting that sort of a question, because I think actually it was really helpful to spend the time and listen to people, to hear what people thought was important. And I suppose I think of it in several different ways. Some of it was obviously around about waiting times and kind of the frustration and, you know, the impact that waiting times had in a number of areas. I mean, I've picked out particularly access to autism and ADHD assessments. We talked to several parents groups who were very kind of challenged about the implications of waiting and what that meant in terms of their lives. So we thought about that, and obviously one of the things that we are doing is kind of pumping in some money now to try and bring down the weights, but we're also looking at how the services is delivered in terms of kind of thinking about how you might do that differently. So that's one example. I think two of the ones that really struck me was around about how many times people said that they found the transition particularly for mental health for young people moving into adult services really difficult, and the need to kind of be better prepared and better supported. So we've tried to think about how we would do that and how we would measure the impact of that. And one of the things that I was thinking about, and we were thinking about, is it's all very well kind of building it into a service offer, which is what we've tried to do. But what I'm also trying to do is, when I come to the bit on outcomes, one of the outcomes we'd like to particularly measure is around about transition. Now, we don't collect much at the minute, but I think, you know, if we are going to see if by putting in some new services, putting in some changing things, getting things delivered in different ways, if that's made an impact, because that's what we're trying to do in terms of introducing new models. But it's going to take a while, because actually we don't really collect anything now to tell us how well we we do. I mean, I think we don't do very well because actually people raised it quite a lot, but we need to put in a system to sort of like first collect the information and then kind of work out if the new services, the changes are making a difference. So that was one of the things that really struck me. And then the third thing that really struck me, and I'm not sure, it's not easy to do, and it's kind of a whole part of the NCL digital strategy, is around about people constantly saying they found it very frustrating, depressing, hard, particularly if they'd had a traumatic experience, to keep repeating their story every time they had a new intervention or they got referred elsewhere. So really thinking about shared records, shared with consent, so that people didn't have to keep doing that. And that's more difficult to do because that's a whole piece of work that NCL is doing as part of its whole digital work. But that was kind of something that I was really struck by us needing to try and achieve as part of this, but recognising it wasn't going to be easy. Was that the sort of thing you wanted to hear?
Yeah. And while you were talking about that, can I ask about sorry, it's slightly unconventional, but just about that, because you mentioned trauma, and just about trauma-informed approaches, because it strikes me that there's a very close relationship within that.
Yeah, I mean, so it was thinking about actually where people had, yeah, I mean, so people were saying that where their kind of issue had, I'm not expressing this very well. What I'm trying to say is that we were very minded that people were talking to us that they were having to repeat what was often a traumatic story, and how did we stop that having to happen? And that was around about how we made sure that there was a good history, and that history got shared, and that it didn't have to be repeated because clinicians, principally clinicians, could read it and understand. But recognising sometimes it was part of the therapeutic response that you needed to kind of unpack some of that. So trying to think about it in two ways, I guess, is the answer to that question.
Yeah, I mean, it just strikes me that that's really important. It's something we've talked about in other parts of both here, but also in parts of the council. It just strikes me as very significantly important in setting out that. And maybe it's not something for now, but maybe it's something I'd just be interested to, I'm sure we'd want to be confident that we were using those approaches, not just in directly therapeutic work, but just generally. And I can see Anne wanting to come in, so maybe Anne.
Thank you, Chair. I don't know if you can hear me because I'm at Cumberland Road. Oh, good. I can see now.
I can hear you, yes.
I just wanted to come in on that point, that I think it's really important that we do find ways across the system for children, young people, all service users, to give their story one time. I'm not entirely sure, Joe, that having systems that connect will solve the problem. And I say that because certainly my own experience, and I think most of us in the room, when we go to the health service, I'm not being critical of the health service, I'm just using it as an example. People are too busy to read the notes and find it easier to ask the person sat in front of them. So there's something that we need to do to give people time to read the notes. We all know, or some of us do, how frustrating that can be. And so I think that absolutely we need to try and find a solution to this, but I think it's probably cultural rather than physical and structural and systems coming together. I think about, wouldn't it be great if we had people on video who have got a minute to tell their story, so that whether it's a social worker, a clinician, or someone who's listening to it has a minute just to listen. But that's a little bit futuristic for me, but I'm thinking, how else do we do it? Thank you. I just needed to thank you, Chair, for allowing me that question. That comment.
Thanks, Anne. And I think that's really helpful, and I think you've summarised it in a way that I couldn't. So thank you. That's really helpful. I do. I think that's right. I think technology can help a lot often, but you're quite right. Sometimes we already have that bit of information. And actually anyone who's even just been through, let's not talk about just in simple services that a lot of us have been through. I can think of my maternity experience. It happens. You will tell your story lots of times, even if there is a book with a lot of written detail and information. And sometimes also I get a sense, I think you're right to use that word culture, because sometimes I think it can be helpful for stuff. I find it helpful listening to the story from the individual, and I suppose that's why I was playing around in that trauma-informed zone as well, thinking about how that will feel like, and what that is, and how well we do that as well, because that the quality of that interaction as well is quite important then, isn't it? So sorry, there's a few other hands up, so I'm going to take you all in the order I think those went up in. So Lynette, I think, then Peter, then Jeffrey, but forgive me if that's not the right order. But Lynette.
Yeah, thank you, Councillor Denise. And I'm really just supporting what Anne said there. I don't think it's about whether we've got a computer system or a database that has all that information. The people that we work with at Mind in Haringey often tell us about stories where not only have they had to repeat their traumatic story, but the person receiving that story was almost judging whether they were allowed the service that they were trying to access, etc. And they often say that journey starts at the GP receptionist, who is the gatekeeper to whether you're even going to get to see your GP. So I think when we're actually thinking about a trauma-informed approach, it has to be systematic. It has to start with a different attitude to those who have experienced trauma. When we look at a borough like Haringey, and I appreciate this is across more than just Haringey, but when I look at a borough like Haringey, there are a lot of traumatized people in this borough, either because they've come in as part of our transient population. Then we've got cultural issues, which means that there are sections of our community that would have experienced multiple trauma based on the systems that sometimes make it difficult for them to access some of these services. So I'm not sure that by just connecting us all in relation to information, that is going to solve this problem. It's really thinking, why do we ask the questions that we ask? Why are we asking them? And in asking them, does that justify somebody accessing a service or not? And do they have to tell that story in front of all those other people in a room, often when they are in the reception of somewhere? So I think we could definitely learn from other organisations. I know in Scotland, because we've delivered trauma-informed training with our BEH colleagues, that in Scotland, everybody is trained in trauma-informed, and that has had a huge impact on the way that people access the NHS services in Scotland. So I think that there's already a lot of learning out there, and this is just sometimes tweaks of the way that we do things that will improve it for those that walk through the door. So I don't know if that helps, but I think if we're going to really think about that core offer, people have to think about a trauma-informed approach where some of the things that they would have normally done before is tweaked a little bit, just to recognise the amount of trauma that we're talking about in our area. And if it's okay, can I just say about young people who are transitioning in the mental health system, the reason that transition is difficult is because when a young person is in child and adolescent mental health services, the criteria for that work is totally different to the criteria about how you access adult services. So I don't think it's linear. I don't think every young person that is in CAMHS needs to transition into our adult mental health services. But what we need to do is ensure that there's not a cliff drop from CAMHS to nothing. And so there's something in that space, so that we're not just directing them to become adult patients of our mental health system. So I just wanted to say that transition is difficult anyway, because we have different criteria in mental health, and I'm really hoping that helps. And it's definitely not a criticism, just what we've learned from the work that we do at Mind in Haringey.
Thanks, Lynette. Some really, really useful and helpful comments there, of course. Thank you. Peter.
I have slightly ambivalent feelings. That I completely sympathise with what it must feel like for people having to repeat their stories. On the other hand, so much of medical training is about hearing the story, taking the story, and hearing it again. And you will find clinicians will repeat the story and want to hear it for themselves, even if another clinician has already taken it. And it's in the telling of the story sometimes that new bits of information come out, new emphasis, And so, as I say, I feel quite ambivalent about this. It's rather difficult because it's so ingrained into clinicians and the way they work. I really sympathise with lay people. I think they sometimes are completely mystified about the questions that doctors ask and the information that the doctor is trying to extract. And it'd be lovely to try and make that easier and more straightforward. But it's a quite a complex interaction, this. But I'm all for the general thrust of it. Anyway, in terms of making it simpler for people.
Thanks, Peter. I suppose the point is, I suppose if I was going to comment on that, just thinking about what I've heard when I've heard from residents, is that, but then that's why we're talking about trauma informed, isn't it? That's why sometimes the story is important, but then it's how that's managed and how where you take the person to the place, but then also we make sure that that's it's in the right context and done in a successful way. And I think probably we're acknowledging here as well that actually we're all under pressure and staff are under pressure. So often you might have that interaction and it might be necessary and important, but it might not, the time frame, etc. and the pressures and the method might then mean that residents aren't left at the right place at the end of that conversation, right? But I think you know that, so I'm not. I just want to contextualise the comments that we've had. I've got Jeffrey next, and then Jonathan and Rachel after.
Yeah, thank you, Chair. That's the correct order. So I'm happy to come in. Thank you, Joe, for presentation. Always good to hear from you. I think just to keep up the things around the trauma informed, I agree with all of the stuff around telling the story once, and I think I note Peter's comment, which is also need to be factored in. But sticking with telling the story once, I suppose, and the collaboration that then needs to happen. I think, Joe, in the presentation somewhere, you talk about looking at opportunities to collaborate or more collaborative working to support sort of the core offer. Now, I'm mindful that a lot of what we're talking here is community services provided by the NHS and statutory. So can you say a bit more what the thinking there is like to be around these new opportunities for collaboration? The second bit, if you don't mind, is all of this is really important, but again, you said there's a health outcome framework happening, and good to see stuff around inequalities there. And I think we've seen some fantastic data coming out of BH, for example, around racial inequalities. So can you, again, give us some assurance and idea how these may be factored into this going forward? Thank you.
Thanks. And I'm also just really conscious, sorry, Joe, that I kind of stopped you midway in the flow. So because it just felt like it's right to answer. There's a lot of detail in this bit. So I'm going to suggest if there are bits of that you're going to come to later, if we can just hold on to that question as well. Does anyone want to come in on this specific bit? Rachel, Jonathan, and then Rachel.
So the conversation's moving on, so that's what I guess what I wanted to do is just bring us back to, I think the how of how people work with patients, that trauma-informed approach is really very much down to, Whittington Health staff being trained appropriately and that sort of stuff. And that's what we're doing. And we will be working with partners on that. I think what the key or the core of this review is about seeing how do we create that standardization, but also impacting on inequalities and inefficient, sort of unequal funding up till this point across North Central London. So I guess I just want to give Joe an opportunity to sort of come back on that point, which Jeffrey has just sort of picked up on, which is what's the gain for some of the Haringey residents who need more perhaps than other residents or other parts of the population.
Thanks, and absolutely, let's come back to continue on with but the only point I'd make is that absolutely I understand what the intent is here, but I guess the point that we're making is that these are residents don't see all those different distinctions and layers, and I always like to bring that perspective, that layperson, that resident view, and their front-facing experience and they won't necessarily make the distinctions between why some of those things are happening. So I think, nevertheless, it's an important point, and we can. I suppose the other point I'd make is we can solve some of those other problems, and that would be good, but that might not change the resident experience if we don't tackle the other things, or put another way, maybe having more funding, perhaps that is something that will also contribute to better training and more time and etc. So recognise. Does anyone want? I'm going to move us on to the but I know there are hands up, but I'm going to let Joe carry on unless someone really wants to come in on this specific slide and things with that. But otherwise, I'm going to move us on, if that's okay.
Right,
Joe.
Yeah, thank you so much. And I can see Alex is kind of joined us now, so I'll just speak a little bit longer, then maybe pass over to Alex to finish off and add the bits he was going to say. To the points that have been raised about inequalities, collaboration, and particularly the voluntary sector, can we come on to that as we kind of go through? And also, I was just going to say, I think a couple of the points that Lynette made, about trauma-informed care and transition were really, really important. And I mean, we could spend 2 hours talking about transition and not even sort of touch the sides. So these are really, really important areas. And I'm, whizzing through this for the sake of speed, but these are really very important areas that we are thinking quite a lot about. If I can move on to the next couple of slides, that would be really helpful. One of the things that we wanted to do, and I guess it picks up slightly on Jeffrey's point about inequalities, was to really think about how the work that we were doing to deliver the core service offer for both community and mental health would support the wider NCL work in terms of improving population health and kind of improving population health outcomes. And the next couple of slides are summary slides of the work that the population health, it's called the Population Health Board, I'm sure someone will correct me, have been thinking about in terms of what they want to achieve or want to measure on behalf of North Central. And what they've looked at is having 7 indicators, so 3 for starting well, 3 for living well, and 2 for ageing well. And what we are trying to do for both mental health and community is to think about sets of indicators that would feed into these broader population health outcomes. So what would be the contribution, for example, of community services in terms of every child has the best start in life and no child left behind? What would be the contribution of mental health services to achieving that particular population health outcome goal? So what we are thinking about is kind of coming up with between probably 3 or 4 criteria that we can show as the unique contribution of either community or mental health services in terms of delivering that overall population health goal. And that's something that we are sharing. I talked to Directors of Public Health earlier this week. We've been talking to other colleagues. We were talking about it at the programme boards. So thinking about what those criteria would look like. And there's only a small number because the NHS and other organisations, we collect lots and lots of data, and that's still going to continue because we still have to do huge amounts of national returns, etc., etc. But we just want to focus on a few that will show us actually we're making a difference in terms of inequalities, or that we're making a real difference in terms of how we contribute to the kind of every child has the best start in life. So that's that's a piece of work that we're doing now. And if people would like to see what we're thinking about for the community and mental health, I'm very happy to share those specific slides which start to set out what we think those contributions would be. But really, I think important that we can really measure the impact of a core service, delivering a core service offer consistently to see actually has it made a difference in these areas. So if we can just move on to the next slide, that would be good. Alex, do you want to talk to this one?
I'm really happy to. I haven't seen the slide move on yet, but there it is. So I suppose the stage that we're in, as Joe talked through, is with got a core offer that's supported both clinically and by the programme board. And we're trying to work out how over a period of time that's not so long that, you know, people really need to see the difference it makes on the ground for all of the things we've talked about. We're really looking at kind of 3 years. We want to make a lot of impact in 3 years, really how we fund it. Because what we don't want to do is obviously destabilise existing services, because, you know, the history of the funding variation is the history of the funding variation. And so we've come up with a mix of things that we are working through that for community in particular, because it hasn't got something similar to the mental health investment standard, where lots of new money's coming in, how we use this mix of things to inform the thinking of how much extra funding there's going to be next year and where it will be targeted to as well. So we know that there's variation in the productivity of different services between providers, and I know providers are really keen to talk about that and collaborate around what some of the good practices around certain things. So as an example, in some of our bedded NHS care, we've got hugely different lengths of stay. It's not just the model that informs that, and we spend an awful lot of money on bedded rehab care in North Central London. Just through the NHS, it's around £29 million. So is there an opportunity through collaboration to perhaps release some funding that can go to caring for people in the community, which is what we want to do? Are there areas where there might be opportunities to work at scale? I really passionately believe the delivery of services needs to remain local in a place. It's the relationships that are really important, whether in community or mental health services. But we know there's some services that actually are quite standardised or struggle to get specialist staff. And where we've got that case, and we've got experience where we've tried to provide funding for things in some boroughs in the past, and however we recruit, we haven't been able to secure the staff necessary to kind of run the service. So we need to think differently about that and see if there's different ways of new roles, blended roles, different ways of delivering things, and there might be opportunities in that. We obviously know, and Whittington as an integrated organisation has been doing this for some time, that you know, the strength of community services really supports what happens in acutes, and we want everyone everywhere to be able to realise those benefits. And it's one of the things that we're talking to acute directors of finance about. And linked to that, I think there will need to be some redistribution of resources where perhaps kind of footprints change. And we're at the start of some of those collaboration kind of discussions. But for example, Whittington Health have been thinking about how they work differently over Haringey and Islington for some time, and lots of colleagues in this room have been part of that discussion, and where we go next regarding that, I think, is really also important. So and also we get growth money. We have tried to, as we did last year, it's often targeted at very specific things that you know, people will say we have to spend it on the urgent community response or the model in the national guidance of anticipatory care. We have tried to really target at areas that have gaps, that don't have the maturity of the clinical model in place, and we are committed to trying to continue to do that, whether that's in mental health or in community services. So we're still working through how much we can invest next year for community, and we obviously have the long-term plan mental health investment standard, which there's a plan for. I'm really conscious of time, and some of this is in the discussion, and I know that you'll have had a chance to read the report earlier. I just wonder whether, in terms of, we can go to the next step slide and just really have a discussion about what some of this might mean and what people's thoughts, feelings, particularly for Haringey are. I've worked in Haringey, and I know that there are some services that are fantastic, and I know there's some services that we haven't been able to invest in previously, and I know that it causes real challenges across the system, and I just wonder if we should spend a few minutes reflecting on that, because I think some of that work about where we start will be really important.
Thank you. Thanks very much. That sounds like a good place to start. I've got a few things, but I think I've spoken quite a bit. I'm going to bring in, and I know we had some hands up from before. Rachel, I'm going to bring you in first.
So I hadn't completely thought about the where to start question, but I do think it's a really good one, and I hope we can sort of focus the conversation. I wanted to ask a similar question, but maybe from a slightly broader lens, and I'm sorry that these are slightly difficult questions. I think there's a huge amount of fantastic work that has gone on to defining what this kind of core offer should be and setting the aspiration that we all achieve it. I wanted to ask whether we have done that kind of view that puts the boroughs alongside each other and then would see what the distance is from that core offer. That's my first tricky question. And then I think somebody mentioned it before about the difficult bit with this is kind of how we go forward in delivering on that core offer. And I wondered what we've obviously got some really difficult kind of decisions to be making as an integrated care board about how we put ourselves into a position where we have investment to put into community services. And I just wondered if you could say something about what you think are the next steps for the integrated care board, for potentially providers or the provider alliance, and for us at place level. What do you think is the kind of contribution and the next steps that we can make at those different levels?
So one of the pieces of work that we try to do in trying to answer the first question, we have a gap analysis which has been completed by both provider colleagues in each borough and essentially their local commissioning lead working together to assess for the things in the core offer. Is it in place, but also does it meet the requirements of the core offer? Can it offer the kind of intensity of work? And there's lots of variation between the boroughs, and it's roughly as you'd expect it to be. The further south you go in NCL, the more of the core offer is completed at the intensity required. What I would say around some of the new things around central point of access, care coordination and trusted assessment, I think that there's examples of people who've really started that journey, and there's lots to learn from each other on. I think those bits are less, I think, maturely developed. And when we had the support of Cardinal Farah, they were really saying some of that will drive the difference. But what we also know is you can't really do care coordination and trusted assessment if you've not got sufficient district nurses to go out at 2 in the morning when people default to hospital as a result of that. We know, and it will come as no surprise to you, that we've been less able to invest in Enfield and Haringey in terms of community services historically, and we know there are tremendous challenges in terms of children's services, both in physical and mental health, and they're some of the areas, I suppose, that we want to find, firstly, how we are going to fund, and it will be a mix of those things, and release the resources to do, and actually get a bit of analysis and discuss it with you. I think it's really important to about where we'll make the biggest difference, because what we probably need to do in order to, I'd really love there to be a community health investment standard in NCL. It's one of the discussions that we'd really love there to be, in a similar way to mental health investment standard. I suppose one of the things that's going to persuade people around that is that it really makes a difference to where resources are spent elsewhere in the system. I hope that provides a bit of an answer. Jo, do you want to pick up how, in terms of the next steps that we are planning to work with boroughs, because I think it's very important, and you suggested ICB and involvement as well.
Mute, Jane.
Thank you. Sorry, I think Rachel may have alluded to some of this. So as Alex says, we do have the gap analysis, so we do know, as I won't repeat what Alex has just said. I think what we're looking to do is to bring, I suppose, we're trying to secure the amount of funding, so we're sort of more definitive about how much money we've actually got, and we hope to do that quite shortly. And I mean, just sitting here, but France is our accountable officer and also our lead, our SRO for these programs, and she is really pushing that we get some additional funding into community as Alex said, there is funding into mental health. So that's really good news. I think what we're looking, Rachel, is a kind of initial discussion in a couple of weeks, which I think you've been invited to kind of set out some of the parameters, because as Alex has said, there are parameters, because, you know, one of the things that we are looking to do is use system investment into community services, and there's a kind of a payback to the system, particularly the acutes, as to what they get out of it. So we need to think that through. But I think we are proposing discussion about what there is in terms of funding and what some of the priorities might be, and then probably local discussions as to, well, what does that actually mean? What do you think is important in terms of what needs to be done? Where do you think the priorities lie in terms of this, I suppose, menu of choices? Because it's not going to be, you know, it can go into any service. I think we've got a view collectively from the work that we've done what we would need to do to deliver the core service offer, and then it's your kind of nuancing and understanding of things that are really, really important in Haringey. But I guess it's a process that we'll be going through as this month, you know, in the next, I don't know, 6 weeks, because we will want to get it to conclusion by the end of April.
Thanks, Joe. And I suppose the comment I'd make as well is a recognition and an understanding, I'm sure this will be obvious to everyone on this call, that also that gap, what the long-term effect has, or that has been of that gap, and how that interplays with the inequalities and disparities we already see in the borough. So, because what we're dealing with is not only, aren't we dealing with, yes, there's a gap and a difference, but also that will have had an effect on our community, which no doubt will have compounded some of those inequalities and disparities that we were already seeing and that we were already trying to combat, right? And so forgive me if I'm stating the obvious. I'm going to bring Anne in.
Thank you, Chair. Joe, thank you very much, Alex. Thank you very much for the presentation. Joe, I just want to start by saying that I'm not, even if it's been sent to me, I don't feel cited on the community's presentation. So it's kind of hard for me to get my head around it. And it's taken me a few iterations to get my head around, a little bit around the mental health one. So if you don't mind if I can contact you outside of here, you know, because these are really, really important reviews and processes and structures and all the rest that we're forming. But I don't feel that I've got as much as a grasp on the detail as I'd like. And as I say that, I sometimes know that when one person speaks, that others might be in a similar position. I don't know if I'm alone. I might be, but there may be more that want to have more detail about the community services work, and for example. So, Joe, again, you won't be surprised to hear me talk about, and others in the room won't be surprised to hear me mention equality of outcomes. So yes, it's nice to have a local offer, and I think that's right. You know, and we'll agree what, you know, there'll be a decision about what goes into it. But it's that point I've made in other rooms, Joe, that 6 units of something for a young person in Northumberland Park is not going to achieve necessarily, all things considered equal, for somebody who's well supported, doing well in education, etc., somewhere else in NCL. So I'm really, really interested in the equality of outcomes rather than delivery of widgets. I use that phrase. One of my old directors used to talk about assessments and widgets. That was one of my points. The issue then about communities, as I say, I don't understand it very well, is about where at different baselines. And I've heard reference to that, so I won't speak too much about that. But I just wanted to bring in a point that was raised, maybe in this room the last time, about the number of GPs, and for example, and I was told that that's NHS England and not within our control. And for me in the community, I might be wrong, I don't know, but I've heard people speak that we have fewer GPs in Northumberland Park and in our more stressed areas, and if we don't, and addressing that would be helpful to delivering outcomes over time. And so therefore, can we invite them into this discussion? Because actually, not solving that or addressing that over time, this might be a structural issue that means that this approach is weakened. Another point I had is about connecting this to the issues that get us here in the first place, bringing in the police and how they, and section 135 and 136 approaches, and the work that Lynette's doing. You know, that yes, we can have the local offer, but actually it's the wider system. How are we engaging with that and those issues, so that this isn't just about the contracting of services, and I don't want to boil it down to that, but actually this is an opportunity for a whole system change piece. I think that's what we set out to do. The other thing in line with that is the work that Rachel and others are doing on the borough partnership plan, as well as the work that the council's doing on the plan. Will there be a coming together of all those points? And those are my points. Thank you very much. Thank you. Sorry there were so many.
Do you want me to try and answer some of that?
Yes, please.
Gosh. Anne always has some really challenging points. I suppose what I would say is happy to share information on the community and what's happening on that, and I can fix up to speak to you separately. That's not a problem. That's the first thing. I absolutely get, and we've talked about it before, your point on equality of outcomes and kind of proper comparisons in terms of need. But I suppose the point I was just going to say that unless we start off with everybody having access to some widgets, we can never kind of move on to get the right number of widgets or offer into place, and we haven't got that at the minute. So even though it might not address the point you're making, we aren't at a starting point to say that we've got at least a similar, the same consistent offer. Even if it's not quite the right offer for some people, we can build on that, but we aren't at a place that we have that first offer yet, so we have to put that in place, and that's what we're trying to do. I'm not going to get into a discussion with GPs. I think they're really important and kind of a critical part of how boroughs work, but I think that's a kind of a local discussion about what needs to happen in the borough. And kind of, again, coming back to the point, we are focused on community and mental health. That's the bit we're doing. I absolutely recognise that that community and mental health services sit within a much wider framework, much more wider delivery partners. But I think, you know, kind of for the sake of the danger is that everything becomes so vast and kind of big, and nothing gets done, and that really isn't what we want to see. So we are focused on what we're focused, but that's not to say that we think we're doing it in isolation, because we don't. And we were trying to work really closely with Rachel and her colleagues and borough partners to engage and address a number of the issues you're talking about, but just thinking that community and mental health make a specific contribution, and we want to get that bit kind of better than it is currently, and that's what we're trying to do. But I will expect to work really, Alex and I will expect to work really closely with Rachel in terms of what is delivered and how it gets delivered into Haringey. But in a sense, you're the local experts on that.
Thank you. Thanks, Jo. Councillor Brabazon.
Thanks, Lucia. I apologise for missing the beginning of the meeting, but I was at the government. There was a webinar with the government for half an hour about Ukrainian plans for Ukrainian refugees, and we may indeed be talking about that as very soon as government plans realise. And I will need to tell you what was said about safeguarding. But I'd like to address the issues of mental health with the bits I have heard. And forgive me if I am off-piste slightly here or slightly parochial, but for me, mental health is many people might agree, a bit of a Cinderella type of service, and one that doesn't get the same attention that physical health gets, and yet we know how serious the issues are. And I was looking at the Start Well slides when they were up on the screen. And for me, one of the big issues in mental health is that it's so hard to get hold of people. It's so hard to engage with whatever the structures are, and getting support for when you need it to help people. For example, and you've heard me say this before at this meeting, so I am repeating myself, to get an assessment for housing. We have endless families living in overcrowding, in stress, who may not be physically ill, but who may have mental health issues which emerge because of the overcrowding in which they're living, or, as Lucia and I know from our casework, because of having children with special needs and all the mental health issues that emerge from the pressures of the families. And I don't know what assessment we have where when people are assessed for housing, they can get the support from the mental health services in order to be able to move up the list or to get rehoused. You know, the council itself has a doctor who's an external contractor, I think, but it's coming all in-house now with Homes for Haringey. And I think there are some opportunities here to work better with mental health to help families where we know they're saying there are crises. They're not physically ill. They're people are just suffering terribly, and I don't know how any of that works. That's first point. And linked to that, and I've said this before, but now we've got people from mental health here. I really, really think we need to have a really good look at how all this interacts in the community mental health services, where local people can be affected by people who are exhibiting bizarre behaviour, and we can get the mental health services out. I know that from my own experience. I've raised it here. It's not just me. There is a system. I think there may be some systemic problems in those relationships of working with the services, and I would like to see some of that addressed as part of our move to work better together as North London partners, and in the partnerships and all the things which I may not be as au fait with as all of you, but I think you get my drift. Thank you.
Oh, excuse me, sorry. I just wanted to paraphrase a bit. I think there was quite a lot in there, Zena, but I was just going to suggest, I think that you're right that we are contacted often by residents across the borough who actually generally really care about their neighbours, and we have a very aware and supportive, I think, for the most part, borough. But I think there are times in which people are their concern spills out because someone's going through a crisis, or perhaps because there isn't understanding of what is taking place, but also because there are so many pressures. I think you described quite well, Dina, some of the pressures that many people are living with. And I think that very much speaks to the points we've made about deprivation and those indices that we know about, and inequalities, and the problems that we know housing is a significant factor. But and I'm just wondering whether or not Cassie and Charlotte, do you want to come in on any of those points, or were you making new ones? Sorry.
New ones.
Okay. And Joe, I don't know if you want to reflect on any things that you said before we move on.
I mean, I think we would all agree that mental health has been underinvested, and that acute physical health has had kind of primacy, and we understand why. I think, kind of over the last couple of years, there has been that recognition, and there has been that attempt to rebalance in terms of investment in mental health. And Alex has talked about the mental health investment standard, and the amount of additional funding going into mental health services. But I think, 2 points I'd make on that. One, the demand is going up. So however much more we've put in, there is more to do. And I think everybody absolutely recognises that. And I guess the second thing to say is that whilst we think that mental health services have been underinvested, we also think that's true for community services. And kind of the point you're making about the needs of people who have both a physical and a mental health was one of the reasons we chose to do the reviews in parallel. So we are thinking about how we get better integrated working between our community and our mental health services to support local people. So that would be the first thing. I recognise all you say about the kind of the impact of deprivation, about people in unsecure, difficult housing circumstances. absolutely recognise all of that, and I know that BEH are kind of thinking about, with the new investments, about how some of that could and will be improved, because one of the requirements that we have had to and wanted to invest in is into community-based mental health services, and that will help some of those local workings where there are kind of people who are needing support. So there is more money and more service going in, but you know, these things take a while to come through, and you know, as you've said, demand is pretty enormous. So not we're chasing our tails, but there's always lots more to do. And the only other thing I was going to say is, one of the things that I talked a little bit about, and Alex mentioned, was about the creation of a central point of access, and thinking about how that might make services a little bit more accessible for people to know who to contact, and then to kind of be helped to find the right service that they might not know about, or they might not be in touch with. So we are thinking about that. I mean, just you know yourself that demand is very great, and we're all trying to play catch up to do the best we can. But there are there are many things that we're trying to do to address some of that. Although you know, I know it won't ever be enough. And you know, you've just mentioned the Ukrainian refugees. You know, every time you think you've done something, there's more to do.
Thank you. And Rachel has put something in the chat, and I'm just going to read that because anyone who's watching or online won't be able to see that. Quick response to Anne's questions re primary care workforce. Since it's not in the scope of the service reviews, Haringey position with primary care workforce very challenged, but an improving picture. Many initiatives underway, in particular employment of pharmacists, social link prescribers, paramedics to support practices, investment in technology and practices, significant investment in primary care estate in Haringey at the moment, increasing numbers of teaching practices. Currently 66% of Haringey's patients served by teaching practices, and we are looking to increase this. And we did have a very lengthy conversation about primary care, and actually every time Rachel and I meet regularly, and every time we do, I talk to her about that. No surprises there. It's the biggest, most significant area of complaints, and I have people, let's be blunt, queuing up to talk to me about it constantly. So I think we're well aware, and it's an issue that's very visible, and it does have waves and impact across the system, doesn't it? I'm conscious of time, so I want to bring Cassie and then Charlotte in.
Thank you. I had a couple of questions, but just to add on to what Rachel's just said there, also the fact that our federation runs the NCL training hub as well as Haringey training hub means that we are absolutely prioritising and thinking about how we can encourage and support GPs to come and work in all parts of Haringey, and we are frequently talking with the CCG and with Health Education England to think about this, not just GPs, of course, the wider workforce. So I think it is something, it absolutely continues to need lots of work, but it's definitely something that we spend a lot of time thinking about. What I was actually going to say, though, was first, I guess I do really welcome this piece of work. I think it is a cause for hope and something where you think, actually, if this can shift, that would be remarkable, having been in the system quite a long time. And I really welcome both that sense of we need to actually take action and aim for sort of the 3-year thing, and the fact that you have developed sort of various approaches to how you might release the funding to enable it, because I think that's critical. We have to be as flexible as we can, because I think we all know in the current world this isn't easy. I guess I guess I feel somewhat anxious about this concept of efficiency saving. For all of us, we know how many years we have been trying to extract efficiencies out of our systems, and I'm sure there are more, but often in my experience, some of that efficiency requires investment to shift and change, and it requires time, and you need to, and so I guess I just wonder, given the current pressures and how much has gone before, how realistically you think there's and it maybe is unanswerable, and so apologies again for a hard question, but what the potential really is to achieve those efficiencies. And I guess my other thing, just gosh, that those two sums for community services in Islington versus Haringey, the 98 versus 192, and that is massively sobering. And I think, speaking as Haringey, we can go, great, it would be lovely for that to be equalised, but I could imagine this conversation not playing quite so well in Islington. And so any thoughts that you have on how realistically that can be achieved without it feeling like it's just a drain? And yeah, that I know it's hard questions, but that's just some of my concern and wondering.
Thanks, Cassie. And I think I'd just add to that, but my point was also that equal isn't always fair, and we have to, and I feel that mix, because we're going to be assistant an NCL system. But you're right, with my Haringey hat, I would say we would have seen I would have thought negative outcomes from having had that negative difference, and so we owe our residents, with our Haringey hat on, we owe them, the fairness of service, and the fairness of shot at having the health and support clearly they need, and that clearly they haven't been getting to the right level and extent, right? So I think those are really, really difficult questions and hard for me, completely. So, and I don't know that there are simple answers. Joe, I don't know if you want to come in before I take Charlotte.
I'll just take 2 points. On the efficiency, I mean, you're absolutely right. I mean, the system chases efficiency all of the time, and we're not very efficient at it. We've had some conversations with providers about some areas that they could look at in terms of skill mix, in terms of how they work differently. There is an expectation, and particularly I have to say, coming from some of our acute colleagues, that if they are going to give up some of their funding to support community, that they want to make sure that that money is well spent. So they will be pushing on efficiencies. But I think providers accept that they have to try and do things differently and look for opportunities. So I don't know what the answer is, and we're not necessarily expecting to get huge amounts next year. But in terms of discussion and opportunities, we think, I mean, Alex said that we had partners in Carnell Farrell. They calculated, I think it was about £2 or £3 million worth of efficiencies now. Management consultants always, it's part of their job, isn't it? But they did give us some ideas and some areas to discuss with providers as possible opportunities. So not giving up on it, but we think that there'll be something. And then just to say that, yes, there is a kind of discrepancy in terms of funding between Islington and Haringey in terms of levels of investment. I think we've always been clear that this wasn't about levelling down or levelling up. It was trying to understand need, which is why we spent quite a lot of time working on gap analysis, working on a consistent service offer. And then, it's why it's going to take a couple of years to be able to increase the investments in those areas. Haringey would be one, Enfield would be the other, where Barnet to a certain extent, where there is both inequalities, there is evidence need, and there has been less investment over the last few years. So we've already taken a bit of a differential approach to this year's investment, and I think we will continue to build on that. But we have to recognise that if we talk to Islington colleagues, they certainly don't think they're overfunded, and certainly think that they have got, that actually they are scraping through. So, but we're aware, I think it will have to be a targeted approach, and that's what we've said as part of the programme.
Thanks, Joe. And I recognise everything you're saying. I think everyone does on this call. But I suppose also we have to, if we're serious about prevention, if we're serious about that kind of intervention, if we recognise we don't want people to be in acute, we don't want people to be having, the longer things go on, the more multiple issues that they see in their health, the more complexity that, also the more expensive it gets, the more difficult to treat. And then the more we see them in long-term social care, we're serious about that, then we need that investment, and I know everyone knows that. Charlotte, I think you were next.
Thank you, Councillor Dawson. Sorry, I should take myself. Is that better? Can you hear me? Okay, yeah. I guess I just wanted to pick up on your final point there, that I feel if we are serious about those things, then that last point about how we engage at place is really important on the next steps. And I'm still slightly anxious that we're not making enough of those next steps in terms of really connecting with what is available at place, whether that's primary care, community sector, local authority, provided services, things that are delivered through schools. It just still feels like it's provider talking to provider, and I really want to push us on the next steps, really, because I don't think we all want the shift at early intervention and prevention. We talk to a set of purely NHS providers. So I'm maybe being a bit more challenging, but I just think we are genuinely going to talk about moving it to place. And that's a very different conversation in that last summary of next steps point, and we really need to focus our attention, and I mean sort of investment attention, resource attention, thinking capacity attention on how we deliver that. And I'm not really seeing that yet. So it's really just a push for some understanding of the how.
Thanks, Charlotte. And I agree. And I also agree that if we talk about efficiency and being effective, being efficient, being effective, maximising what we do have, then we have to answer the questions about how we're going to work better together, what that coordination is going to look like, how it includes our community, how it includes our voluntary sector, and at all level on how we mobilise. Because what we said about the pandemic was we said we'd learn that lesson. We said we'd recognise that inherent value in the community, and that we would not let that go, but instead we would build on that and recognise that we cannot do everything, that we don't have the funds that we want. But that means working well together. That's the hard bit. But that's also the bit where we could really achieve. But we also have to, there are different cultures of organisation here, and we're trying to navigate that, aren't we? But I feel really strongly about that. And the flip side is we sometimes do unintentionally cause harm because we don't work well together. We do. So we need to be really straight and honest with ourselves about that, and about what efficiency and effectiveness means. You know, yes, it might mean people not repeating this room. Yes, it might mean us not duplicating work. It means how we work together well, and how we have of one mind, and we recognise those outcomes that Anne was talking about earlier, and having those shared outcomes. Just looking at who else, and I'm conscious of time as well. I think Councillor Brabazon was next.
Thanks, Lucia. I think you've summed that up incredibly well. It is about how we work together and we maximise the resources. People use it, you know. So if I go back to some of the points I raised, which I feel we've sort of touched on, you know, in the generality. For example, in early years, and families and children families, if the parents have mental health problems, then it's going to affect the children. So we know that. This is not new news, is it? And we know if people are under stress and so on. So I just want to come up with some sort of pragmatic approach, and I ask you to follow it up just to see if it's possible. Housing is gatekept. That's the problem. There's more need than there is housing, and so there's gatekeeping, and it's rationed, and it's done by allocations, it's done by banding, it's done by all sorts of strategies which make it, you know, people have to go through the hoops. And as I said, the council itself pays for medical assessments. Has mental health ever talked? Have you had any liaison with the housing people to think about perhaps that we as a council, I don't know, Lucy, I might put my foot in it, might be able to commission equivalent on the mental health side of things, so that where families are really in crisis, they get an assessment. Because if we don't get all that right, and if people fall through the net, it impacts on the children, impacts on children's social care, impacts hugely on the council services, and leaves the families in limbo because their state of mind may not be recognised as a condition, like having bad back or a physical condition. And I just feel we might be missing a trick here. So Joe, I just ask you to think about that when you think, because I think, for want of, if it did cost the council so much to commission it, maybe it'd be worth it. I don't know, Lucia, maybe a daft idea, but I absolutely know this is all about gatekeeping. It's all about rationing. And if we leave it late, the situations, as Lucia said, get worse. And I'm worried our children's social care, I'm sure I don't see it all, but the social workers and Anne are seeing what's out there. And we have to be mindful of that. And we can do that through safeguarding partnership or whatever. But we've got a chance now because we are reshaping our housing service. This is the time to look at it. Thank you.
Thanks, Sina. And I think it's good to challenge and for us to think differently. How could it look differently if it did? Even if it seems off the wall, even if it's not possible. I think that's good. That's a really good thing from my perspective. I am conscious of time. I am going to bring in the last two speakers and then move us on. But I think what's clear is we need to come back to this conversation, don't we? And so maybe if while our next speakers go, if we could just have a little bit of a think, Joe and Rachel, about where we go next with this, and maybe we want to bring the conversation to Health and Wellbeing Board, or have another discussion outside and then come back, what have you. But I think there's lots to discuss and lots of appetite and lots of things to tackle within that. Nena, I'm going to bring you in.
Thank you so much, Chair. Firstly, I'm going to say that this is a moment in time for us to get it right in terms of what happens in the out of hospital space, and it is right and proper that community and mental health are being spoken about in the same breath, because we know that by improving the out of hospital provision of mental health services, but also of physical health services, it would make such a huge difference, not just to admissions to hospital, but actually more importantly to the life and quality of life of our residents. I'm also just highlighting the outcome-based approach to the specifications, which I think are important. So we had that conversation about widgets, and I think that access is both an outcome and a process measure. So it is an important widget to measure, difficult as it can be sometimes to measure the unseen elements of that. Funding, I'm really quite delighted, to be honest, with the progress that's been made in an area that's not easy, and that people have taken on board the difficult conversations, recognizing the need for funding and recognizing the need for us to find a different solution to where we are in a staggered way over time, because efficiencies take time to be released. I do also want to highlight the place-based vertical integration and integrated pathways opportunity, because when we talk about community, it is the fluid between primary and secondary care that really makes the lives of our patients and the touch points for our patients much more effective. So it's just to lend my support to the importance of this and the progress that has been made, and to the continued conversation that is really critical at this moment in time.
Thank you, Nena. It's good to hear that. Thank you. Good to hear from you. Jonathan.
Yeah, just to kind of pick up on a few points that other people have raised. One is that sort of the resources and the shifting of resources. It's worth just noting that, Whittington have over the last multiple years been already sort of trying to even things out, because of course we manage both Islington and Harringay, and we've wanted to make sure that the pathways are similar and the resources are similar across. So we've already beginning to do some of that, which has borne fruit, I think. But it does leave a question about that additionality that might be needed in certain areas for inequalities that we need to pick up on. I did want to also pick up on that definition of efficiency, and sometimes that efficiency is measured by number of visits per district nurse on a particular day, and I think what we would argue is that that's often not a great measure, because particularly given all the things we were saying about linking to other services, isn't it better that a district nurse spends a little bit more time and solves more problems of the individual that they're seeing, rather than goes in, does the little thing that they've been asked to do, and goes out and says, no, that's somebody else's job. And I think that's the thing that we're also trying to do from a Whittington Health point of view, is to get it, as Nena says, effective efficiency. And then I think just picking up that point about linking to localities, and I think that's something that absolutely is happening on the ground, as you know, Councillor, and it's just going to be really important that as the next steps of this review come through, that, and I don't think it will, so it's not a sort of a big risk, but it is important that that doesn't undo the stuff that's going on the ground in terms of the way that we work, accidentally by sort of creating such a rigid service specification that then doesn't work really well with the way that we work across voluntary sector, acute and community. So it's just going to be important to keep an eye on that.
Thank you. Those are really useful comments, Jonathan. Rachel, you wanted to come in?
Well, I just wondered whether it might be helpful to put forward some thoughts about next steps with this.
But I see Alex wants to come in as well. Maybe Alex, can bring Alex in first, then, in case it's on the comments Jonathan's just made.
I think also, not and building on the comments Jonathan makes, lots of the things in the core offer are, I mean, we started making extra investment in Haringey compared to Camden and Islington, just being honest, in some of the community support for anticipatory care last year. And so I know these are discussions that you're having in your place-based teams now, and I think it's very much in line with that we see the implementation of the core offer happening. And so I just wanted to, that there's stuff already in train, as well as there's going to be some new bits that no doubt in terms of the next steps. And I realise that's a whole partnership effort between primary care, community, mental health services, etc., and social care around that.
Thanks, Alex. And before I just go to you, Rachel, I just wanted to make a little small point as well, which was that, I mean, I had a few questions and I can always follow up over email with you, Joe, but I just want to make the point about the engagement with residents, political representatives, and just making sure that always happens and happens throughout processes, because we're a good path and a good route through to residents and often to networks that I know that health and other colleagues might not have, but also residents have that expectation that we know what's going on, or that we know what the questions are that are being asked, and that we are in some way asked, or they have that expectation because they will expect us to be feeding in, because we'll be familiar with some of the things that they tell us every week and every month and what have you. So that's just, I think that's an important point for me to make, that, and a plea for making sure that we are engaged. Obviously, for me, I'm chair here of Health and Wellbeing Board, but there are, many others of us around, and also because it's a difficult period as we're going into an election, etc. But nevertheless, I think it's important, and I think residents expect it. Rachel.
So I think it has been really useful to have this opportunity to take stock of where we are with the community services and mental health review as a borough, and really kind of familiarise ourselves with it. I'm wondering whether it seems to me that there are a couple of next steps that will happen at an NCL level that will set some of the parameters. So things like, is there a level of investment that is available, and are there certain kind of principles for how we move forward, and certain priorities at an NCL level that in a sense kind of clears the way and is what we must use as a kind of starting point. But then I think it's really obvious from this conversation that there is a huge amount of scope for us to look as a borough at what we think our greatest kind of gaps are in relation to the core offer, what we're already doing and what we're not already doing. But significantly, which of those gaps have the most impact on outcomes? And some of them will be a kind of absolute resource gap, and some of them will be a way we work and a kind of more of a culture gap. But there is probably a fair amount, and particularly if there is some additional investment that is within the scope of us as a borough to really think about. And I think, Charlotte's challenge was really appropriate and apt. We have to really think about the interconnections between primary, community, mental health services. And I thought Councillor Brabazon's points are really interesting as well about, asking ourselves the challenging questions about if housing is the sort of root cause of many other issues, then what do we do? What's our approach as a borough? And so I wonder whether we then are going to want to set aside potentially a couple of our health and wellbeing board seminars to really focus on that gap analysis and on what we think our priorities are, what we think will have the greatest impact on outcomes. And I think what's interesting about it is that it will be a real challenge for us as a borough. I think, you know, it will require a lot of transparency about how services are resourced at the moment, how that varies between boroughs, about what of the community services has the greatest impact on acute services, because acutes are being asked to be part of the investment around this. So in that sense, I think as well, it is both a challenge and an opportunity for us as a borough partnership. So that would be my suggestion, and I think maybe the timing of that is that it will be a post-May type of conversation anyway, which I think is appropriate.
Thanks, that's really helpful, Rachel. And I also just wanted to thank Alex and Joe. Inevitably, we were going to not have enough time to discuss all the things we want to talk about. And these services are so vital to everyone in Haringey. So thank you. So it's a good start to the conversation. Thanks very much. But I'm going to move us on promptly, because we have Dan and Thomas in the room, and so in the room virtually. So I'm going to just vary the agenda a little and take the long COVID item now, if that's okay, and then we'll come back to item 9 after we've done item 10. So we're on item 10, everyone. Rachel, do you want to just introduce Dan and?
Yeah, thank you very much. Dan and Tom, thank you so much for joining us. Dan Windross has been leading from a management perspective across NCL on long COVID, amongst many other things. Tom Leonard is a GP in Haringey and has been part of working in and developing the long COVID service. So they are going to talk to us a little bit about how it's all working, and particularly about the kind of scale and impact of long COVID across NCL and specifically in Haringey.
Great, thank you for the introduction. Yes, as Rachel said, I'm Dan Wins. I'm part of the strategic commissioning team at North Central London CCG, and have been working on long COVID services. I might just ask Thomas, Dr. Leonard, to introduce himself as well, please.
Hi, yes, Thomas Leonard. I'm a GP partner working in Haringey in the east of the borough, and I'm the long COVID lead in terms of primary care and GP for the MDT in the borough as well.
Thank you. We've got some slides which I think were shared around with the papers for today. I haven't been to one of these before, so would you like me to talk through the slides first, Chair, and then have some time for questions, or do you want me to take them as read?
Well, we could. Do you want to just flick through them just a little, very briefly, really quickly, not long, because I think we will all have read them, but just maybe you want to bring out some of the things that you think are the biggest challenges for us, the things we want to think about, and then we'll move straight to questions, if that's okay.
That'd be great, thank you. Yes, so I'll talk through them quickly. Before I put them on the screen, they do 4 things really. They talk about the condition, they talk about long COVID, they describe the symptoms, the diagnostic classification. They outline the expected prevalence, so the numbers of people that we think in Haringey have long COVID, and I can give you an update on how many people have been diagnosed with long COVID. And I think that's one of the key things I'd like to draw out from today, is the gap between those 2 numbers and what work we can ask your help with in supporting it. I can see we've got Jeffrey with us today, and I'd really like to maybe give him a bit of time to talk about the Haringey long COVID work, which he's leading on behalf with other organisations, because I think that's a really interesting thing that will help us close that prevalence gap. I could talk a bit about the services that we've developed in North Central London to respond to long COVID need in our community. And maybe just to wrap things up, you can see Sharon's here as well, and it'd be really great to maybe talk a bit about watch work that has been going on across NCL, to be gathering patient views, residents' views on long COVID and what the services we need to be doing to, you know, keep meeting that need. So if that's all right, I'll start with the
That's
slides.
great, and keep it short on the slides, just so we've got enough time to talk about the issue.
Will do. We'll go through it quickly. So hopefully that'll be appearing now. And obviously, as I do that, you all vanish.
Thank you.
Okay, so post-COVID syndrome and long COVID. The diagnostic classification is about post-COVID syndrome. Patients use and residents use the term long COVID much more frequently. We're not precious here, but I think it's important just to let you know that they do mean often very much the same thing. This is the technical diagnostic classification. It talks about signs and symptoms beyond 12 weeks as being post-COVID syndrome. But the services we'll talk about here are to help anybody beyond 4 weeks who are still experiencing the impact of COVID. And that's generally what patients and residents refer to as long COVID. The symptoms, they're very, very broad. People have reported a whole lot of different types of symptoms around long COVID. Most common symptoms, things about fatigue, breathlessness, concentrating, loss of smell and muscle ache. Those are the key things, but it is a very, very broad and newly emerging condition. There's different ways of measuring prevalence, so how many people we think have got long COVID, and the slides work through some of that different methodology in a bit of detail. But I think I'll jump through this bit to show you this slide, which gives you a sense of the numbers across the different boroughs in North Central London. So you can see that we're expecting, according to the modelling, around 3,000 people in Haringey to be experiencing long COVID. This recently done in October. We are currently redoing this in conjunction with our public health teams. It's not yet clear what the impact of vaccination or Omicron variant may be on this, so it's very much an emerging clinical picture, but we may be able to give a bit more detail on that. As of November, we had diagnosed around 900 people in Haringey with long COVID, so that's from our primary care data. There's inevitably a bit of a lag in our information, but that gives you a bit of a sense that we think we found about a third of the people who may be experiencing long COVID. The next 4 slides break down that expected prevalence by gender, by age, by ethnicity, by deprivation. So you can get a bit of the sense of the detail in this of how we understand the cohort and where we think some of that need is most likely to be found. I'll skip through those fairly quickly. So to talk about the services, long COVID services, we've envisaged this very much as a linking up a pathway. So starting with primary care, with an assessment in primary care. We've then tried to link together the community services provided in Haringey by the Whittington and IAP services with the specialist long COVID clinic at UCLH for North Central London. So to try and draw those together, we've created a local MDT, which Dr. Leonard sits on alongside colleagues from those other services. And that MDT is the place where where professionals are able to get together to discuss the right place for somebody's care. The slides detail that pathway and they outline a bit about what happens in those different areas. We've got a bit of a slide here about what happens at an assessment, what happens at primary care when you go to be assessed, to be, you know, meet GP to talk about long COVID and some of the things that the GP might do as a result of that assessment. We've got something here about your COVID recovery. It's a really useful resource. There's a lot of good information there on that website and a bit of information here about the long COVID project, which is commencing shortly. And as I said earlier, that's we're really pleased that that's happening in Haringey, and we're hopeful that that's able to going to help us narrow that prevalence gap by finding some of the residents who are experiencing long COVID but aren't yet accessing the support that we think will be beneficial to them. That was a canter through as requested, so I'll bring the slides down. I don't know if Thomas or Jeffrey or sorry, Chair, I'll hand back to you. What would be helpful?
That's fine. Yeah, no. Let's Thomas, just want to check you don't want to add something, then I'll ask Jeffrey and then I'll invite, I can see hands up already. But Thomas first.
Thank you. I mean, I think Dan, you know, the slides give a lovely summary there. At our previous meeting, I spoke a little bit more about some of the things that we're trying to work on to improve those issues that have been outlined. But I think perhaps questions will be a good way to discuss that further than me rambling. So yeah, thank you.
Fine. And Jeffrey, before, it's never rambling, I'm sure, Thomas, but Jeffrey, do you want to come in?
Thank you, Chair. Thank you, Dan and Thomas. Good to see you again. Right. This project is like a 2-year project, which is about a few weeks and months into implementation with royal-free NHS charities and working with about 9 community grassroots organizations. And the idea really is to provide a kind of social model alongside any clinical intervention. I think we all know long COVID is a spectrum, I think, and it's severe in one end, but it could be relatively less. And in some communities like the Somali, some of them don't distinguish. They just say it's just COVID. That takes a long time. So I think there's something about outreach and engagement and awareness to raise what this is, so that people can get the help rather than suffering potentially in silence. So some of the intervention is around setting personal goals, for example, and whether it's around employment, education, doing more in the community, and access to other well-being activities that could also be provided. Thank you.
Thanks, Jeffrey. That was a good quick canter, and I think the first, I think it might have been Peter whose hand. Certainly, Peter, I saw your hand go up first, so apologies if I haven't got the order right, everyone. But let's take Peter first.
It's really interesting. I'm sure the clinic would have thought of this, but I, along with a few million others, have dutifully filled in every day on my COVID-19 app some basic data. And you've seen during the pandemic, where digitally we've been able to harness and collect fabulous amounts of data in a way we've never been able to do before, which I found so exciting. So in the middle of a terrible pandemic, we saw this rapid acceleration of the ability to collect data, which has been wonderful. And so as we come out of the pandemic, we all know, well, we certainly know in healthcare, as we've got an increasing number of people with long-term conditions, which they are going to have to help us with in terms of monitoring. This is a wonderful opportunity in this clinic to invite people who are struggling with their condition to report on a daily basis so that we can collect data on long COVID. We can get quick data and find out which interventions are useful to which groups of patients in that clinic. So I think this is terribly exciting. And it could be that this long COVID or post-COVID clinic could be a wonderful way in Haringey of pointing the way in terms of monitoring other long-term conditions digitally. If we can get our population to take part in that, that would be absolutely wonderful.
Thanks, Peter. Notwithstanding the fact that there'll be some barriers for quite a few people, I suspect, and I suspect they'll fit into those. They might well also map with those 900, those people who are not in the 900 who we haven't found. But of course, that's only an assumption on my part. But your point's made, and points well made, and we've talked a lot about having good data, and also I think it's really important to follow people's journey and growing our understanding. So thank you. Sharon, I think you're next. And sorry, Sharon, I meant to bring you in earlier on the. I'd forgotten. Apologies. On the project that Healthwatch are doing. So apologies.
No, just in case people didn't know, Healthwatch Haringey and the other the Healthwatchers in the other North Central London boroughs have been undertaking a survey of people who believe they've experienced long COVID. I think Thomas and Dan will both know about that. I think it's at the printers at the moment. I haven't got it to show you, but I think the first thing to say is probably in terms of the number of people affected, is certainly in Haringey anyway. likely to be a tip of the iceberg that we're looking at the moment, not least because people have had problems in accessing primary care over the period in question. And in particular, some of our communities found that access particularly difficult, and therefore there are probably a lot of people out there who have long COVID that we don't yet really know about. There are a number of recommendations from this report. I think the main thing that sufferers want to say to everybody is that they want to be believed. A lot of them felt that nobody really believed that they had these ongoing symptoms, let alone recognise how severe they were. There was a feeling that GPs might not, certainly at the time we were looking at this, were not themselves familiar with the various symptoms. The effect on people's families, on their employment, was a big issue for a lot of the people that we spoke to. And certainly one of the recommendations is in relation to well, this would include both the council and the NHS in their role as employers, recognising that people are not malingering, that they genuinely have a condition which will affect their ability possibly to work at all, let alone they work in a normal way. So recommendations there. Recommendations too about the need for some sort of peer support for people that are suffering, often in isolation, with a condition which is so little understood as yet, as well as obviously the need for some sustainable access to primary care as they continue to experience symptoms which will be very varied from one person to the next. I don't know if people heard the Radio 4 programme on long COVID last night. It was absolutely fascinating, that the range of symptoms that people have, and the very interesting theories that are now emerging about the causes of the condition being so prolonged, and levels of recovery being varied as well. So clearly there are big issues that we will continue to face, and all I hope from a patient's point of view is that the system will continue to listen to patients and their very real experiences as we work to find the answers to this. But we'll let you have the report as soon as it's available. Thanks.
Thanks, Sharon. We'll look forward to that, and I think it'd be really good to bring that back here to Health and Wellbeing Board and to see that and give it that visibility. I wanted to add that when we had our the sort of partner or community partner version of this meeting, the point was well made by the Chief Exec of Disability Action Haringey around the support. We've just been talking about mental health, around the support, how we support people who've now newly become disabled. And I know it's referred to certainly amongst the long COVID community, if it's such a thing, if it's a way to describe it, as a sort of mass disabling event in a way, a lot of people suddenly not being able to work as we've read. So I thought that was a very strong point made by Phil from DAH, which is what support will there be for people who suddenly need to cope? And you've alluded to it on the work front and the family life front, Sharon. So I just wanted to make that point, since Phil was made that point strongly at our meeting. I'm going to bring Beverly in now, and then Anne.
Thanks very much, Sharon. Thanks very much, Dan and Thomas. I suppose I just wanted to make a couple of points. This is probably the third meeting today that I've been at where we've discussed long COVID. So the first point, we're really keen from a social care perspective to understand the impact of post-COVID on social care. So we really need to build that evidence base. So your work is absolutely welcome. But I suppose that the question that follows then, is it very much linked to the work, for example, Sarah Dugan is doing across NCL in terms of health and care utilisation analysis, and how we could probably work more closely together to really look at the impact on social care. So more anecdotally, I was in an earlier meeting where we talked about people who usually pre-COVID underwent a sort of 6-week reablement before there was a decision about longer term care. That period now can extend up to 14 weeks. One cannot but think that there must be some link either to other long-term conditions, post-COVID, etc., etc. So just a bit of anecdote there. And then the other meeting I was in was really with the Disparities Unit of Public Health England and DHSC. And really, they're really keen to understand the evidence base, going back to this inequality of access issue of people with long COVID really accessing the services. So my takeaway from those various conversations, and we're also discussing it on a London level, is that really we have to have a way of linking health and care data in order to understand the evidence base for this work. I think it would be really useful if it incorporates not just a long COVID, but also those, frailty conditions, long-term conditions that we feel COVID has really exacerbated. So it'd be really useful to hear your take about how the work you're actually doing can support, in my first statement, our understanding of the impact on social care, and therefore how we can plan, incorporating our planning going forward, and the other sort of pieces of work around the evidence base being taking place across NCL and then more nationally. Thanks.
Thanks, Bradley. That's really helpful. I'm going to take comments and then ask Dan and Tom to respond, if that's okay. Anne, do you want to come in?
Thank you, Chair. My question was about supports to children and young people from a young age, however young it is, up to 25, and whether there were age-specific services. Not so much for the over 18s, but for the under 18s. I don't think there'll be many of them, but I think it's one of those things that it would be interested to know. I would be interested to know more about, particularly is that interface that Beverly's alluding to about whether there's a referral for support into our early health services. So maybe that's a conversation outside of it, but in the first instance, are there services that are specific for under 18s? Thank you.
Thanks very much. Okay, so with Tom and Dan.
Tom, you want to go?
Sure.
Anything you want to respond to the question? Yeah.
Thanks. So yeah, no, a lot to unpick there. Thank you for the questions. I think first of all, I agree with Peter. I think this is an exciting opportunity, across the board, to use learnings from long COVID and COVID in general, and all these services that we're trying to piece together, and to subsequently hopefully be able to attribute that to other long-term conditions, frailty and other things like that. So I agree, it is very exciting. Harvesting that data, Dan might know more. I think that's easier said than done, but very exciting. I think in regards to the Health Watch report, I've seen an early draft of the Haringey data. I haven't seen the full NCL one, and it very much is in keeping with what Sharon was saying there. I think some of the ways we're trying to improve access, we're trying to improve GP education, have been holding educational events. There is a very succinct long COVID referral template on our EMIS software, which we use in primary care. We've had feedback from working GPs on streamlining that. It's a really useful document. It helps to make one think of long COVID, first of all, as a diagnosis, and it breaks it down very nicely in terms of the kind of symptoms patients might get, some of the initial primary care investigations you might do. I mentioned in the prior meeting that it's also very important diagnostically not to get tunnel vision with long COVID, and because the symptoms are so varied, we've got to consider other pre-existing conditions that can have these symptoms as well. In terms of some of the feedback about access, I take those points. I think, as many will know, as GPs, as primary care, we're offering more appointments than we ever have before, with less staffing than we had in 3 years ago, for example. But I'm sure we can always do better. We are trying to improve our staffing of the MDT and bring our waiting times down, which is an issue that we have. I think engaging and liaising with our community health partners, with our voluntary sector, with Jeffrey and his team, and speaking with Healthwatch, I think is going to be invaluable there. I've been speaking with Tanya and Rakshita at Haringey Healthwatch about some of the ways we might approach deprived communities where they don't know so much about long COVID, and trying to reach out in ways. And I think it'd be great to liaise with Jeffrey on that as well, and take that through the Bridge Renewal Trust as well. In regards the linking in with social care, yes, I mean, I think that would be wonderful. I think it's clearly has a huge impact on on people's social circumstances, ability to work, and with all the changes that are happening in healthcare with the new setup from April and the integration, hopefully that's a great opportunity for us to do so. All the pre-existing disparities and inequalities also are showing themselves with long COVID. So lower socioeconomic status, working in healthcare, all of the usual are showing here as to why. That's where the research is coming in, but the evidence is clear. And in terms of the last question there around young people, yes, there is a specific pathway for the under 18s. We refer via the local paediatricians, in most cases at the Whittington, if there is a suspicion of long COVID, and then there is a specific clinic based at UCH where they can be onward referred to. It currently must go through the general paediatricians first before it goes directly there. And hopefully that answers most of those questions. Happy to readdress anything I may have missed there.
Thank you. Thanks very much. I'm just wondering, Dan, if you want to pick up on any more on any bits of the data and the working with social care.
Thank you. Yeah, I think Tom's covered most of it. Just a few extra bits to add in. Sharon, you mentioned the peer support, and yeah, we are very keen to grow this. The Whittington have been testing a version of their expert patient programme for people with long COVID, and they found that that's been really beneficial. It showed a significant impact on people's ability to manage their chronic disease. So that's one of the measures they use in the expert patient programme, but they're looking to roll that out. We're looking to see how we can better expand the reach of that by letting some of the different peer support groups that services are running link up with each other and try and understand which sort of groups and what sort of facilitation works for different audiences. Beverly, your point about linking the data. Yes, we've had a couple of meetings with Sarah Dugan about developing a healthy intent dashboard. So that's one of the technical solutions we've got to bring some of the data sources together. And we're going to keep looking at that. So we'll pick up with her and maybe share some of that detail with you about what it's going to show, because I think you're right. It's something we need to understand, jointly. I think that was most. Oh, and one point, Peter, from your point about tech. There is a Living With app which we're rolling out. This can be useful for some patients. Obviously, it's not right for everybody, but it can be useful. And CNWL have been testing that, and we're looking to expand that. So that's another way that we're sort of trying to provide different methods of support. I think that's probably, yeah. Just the last point. Sharon, you also mentioned employment. We do have a dedicated vocational rehab service in North Central London provided by the Royal Free. So this can help people to get back to work. They can help with discussions with HR, help with discussions about making adaptations. And we're starting to implement personal budgets through that so that people can get sort of personal health budgets. They can get a dedicated amount of money to support them in their return to work. So that's something we're testing with an NCL-wide service in the Royal Free. I think that's all I wanted to add.
Thanks. That's really useful. I'm conscious of time, but I will bring Rachel in just to wrap up. I just wanted to point out that Sharon had put in the chat a point around one of the recommendations out of the Healthwatch work, which is around schools moderating enforcement of attendance when there's long COVID cases. And I'm sure we'll come back and have a conversation about that when we have the report. But thanks, Sharon. That's really helpful. I think it would be good to bring that back and maybe hear a little bit more about how we can work together as we progress and especially on Beverly's point about health and social care and that interaction, and we'll hear more about data. But Rachel, did you want to come in and just wrap up on consciousness?
So I'm not going to wrap up. So if I'm just going to ask 2 questions, but obviously happy for that to be taken outside the meeting for time. I wondered whether there is an indication of whether we're monitoring total journey time from point of referral to being seen in COVID clinics, because I'm just conscious, particularly for kids where it needs to go through a paediatrician. So they'll have been to the GP maybe several times, then waited for a paediatric referral, and I just wonder whether we've got a sense of the range of kind of journey times. And the other thing is, I was just seeing some really powerful data from Healthy Intent this morning that was showing a really strong link between mortality from COVID and long-term conditions. It seemed to be the factor that had the greatest impact on mortality. But when we've looked at the data, we've sort of broken down prevalence of long COVID by ethnicity and deprivation and gender for very understandable reasons. I just wonder whether is there a long-term condition connection or not. Happy for those questions to be answered outside, if that's better.
Well, no, if we've got a short answer, and we could have the longer answer outside, but they do sound like very good questions.
So I can certainly, yes, we do monitor both the clinic and the community services response times, and I'm happy to share that. We could provide that information. I don't actually have the children's wait times, I think, to hand, but I'm sure I can get it. I think in long-term conditions, I mean, I'll ask Tom to come in, but I think there is a link, and I think that is established. But Tom, I'll get your view on. But I think it is recognised as a risk factor, and I think there are some slides in the fuller public health assessment that detail that.
The short answer is yes, there's absolutely a link between those with pre-existing long-term conditions and those more likely to get long COVID. The percentages are higher. The why, I don't think there is an answer. Somebody like Melissa Houtman at the UCH hub would perhaps answer that more. They're doing a lot of really interesting studies at the minute. Prof Banerjee has one at UCH to try and understand what long COVID actually is. What is the mechanism, mitochondrial, etc. I probably can't speak to that particularly. The work's being done though. Yes, absolutely.
Thank you. Thanks, Dan and Tom, very much, and everyone for contributing to this conversation. I think it's really important, especially when we look at those figures. And it might be also that I'd undertake outside of this meeting, just because Tom, a few times you've asked, you know, how can we as a group, and I know we're working with Jeffrey, but it might be just worth having a conversation, I don't know, maybe with you, Rachel, and someone from the team, just us having a bit of a conversation. I'm thinking about some of the other work we've done in outreach in health and public health, that's with Will actually, and how we've reached some of our hard, well, I don't like to call them hard, actually in reality they're often our minoritised communities in the borough, and how, and even how there might be a relationship between some of the things we're trying to do elsewhere and this piece of work in reaching them. So thank you all very much for giving us that introduction to where we are at, and I look forward to coming back when the Health Watch report comes out, Sharon. I think it'll make for a very useful and valuable reading. So thank you everyone, and I'm going to move us on since we are short of time as always, and we're going to go and pick up item 9, just a quick update on where we are and on the various bits of legislation that are affecting where we're going as a group together.
Great. Thank you, Chair. And Rachel and I are going to do a bit of a double act. We've got some slides, but I guess just first by way of introduction is to say that we're in what I think is a fairly fortunate position of stars aligning across our policy landscape. So we are, we have since the long-term plan had three big pieces of legislation stroke policy sitting around us that are guiding our way. I like to do the Health and Care Bill, which is currently going through Parliament, the Integration White Paper, which appeared a month ago now, I think, and then the Adult Social Care Reforms and White Paper Doing Better. And what we want to do now is to just give a brief update on what they look like and what they begin to look like. But I think you can take some comfort from the fact that those three big pieces of policy bases are broadly aligned around some key themes around areas like integration, the importance of place, the importance of systems and partnerships, and the importance of workforce. So I'm just going to give a really quick update on the health and care bill before handing over to Rachel. I'm not sure there's anything particularly new for us to take here, apart from the fact that we are working through it's working through Parliament, and we are working our way through the setting up of the integrated care board by the 1st of July, and our local partnerships over the next few months. We're all involved in different ways through the seminars, the Health and Wellbeing Board, and some proposals as came out earlier about how we really make this work clear in the work that we're doing, for example, in community mental health services. I think I'm not going to say a lot more. I think Rachel might have a couple of recruitment appointment updates out of the integrated care board before moving on to the integration white paper. Rachel, over to you.
So I think just to provide an update that some of the exec positions on the integrated care board have been recruited to. So Sarah McDonnell-Davis, the exec director for Place, Sarah Mansorelli, who is the exec director. Now I'm going to have to find the job title. I can't remember. I'm sorry, I haven't got it to hand. But I think something to do with strategic commissioning, and another which is Ian Porter, who's the exec director for corporate services. So and there are appointments pending for the chief nursing officer and the chief medical officer. Do you want me to carry on, Charlotte?
To go on with the integration white paper.
Fine. So I just wanted to draw people's attention to the definition of successful integration being the planning, commissioning and delivery of coordinated, joined up and seamless services to support people to live healthy, independent and dignified lives and improve health outcomes. I just think that's very much what we've been working towards at Place level through the borough partnership, and I think would very much match with our definition. And the vision is that integration makes a positive impact on people's health outcomes, and that's again very much in line with where we are. Do you want to just so the implications, and we have explored some of these through the health and wellbeing seminar series. We are going to be agreeing some shared outcomes across our partnership, for which we will be accountable for delivery. The integration white paper was really interesting, where the health and social care bill focuses a lot on what happens at system level. The integration white paper is almost exclusively focused on place level, and they are defining that a huge part of working towards greater integration is being able to prioritise prevention and building that health resilience. So in terms of the governance implications for us at place level, essentially by this time next year, each ICS system should have a governance model that allows us to have a shared resourced plan for delivery of services that achieve outcomes and a track record of delivery. And there should be a significant and growing proportion of health and care activity and spend that is overseen and resourced by our place-based arrangement. So it's interesting that they're kind of setting that trajectory and that expectation that the stronger your integration journey, and the longer that goes on, the greater responsibility you take at place level, which again I think is very supportive of where we are sitting and our ambition. So in the white paper, there is an expectation that our governance should have a single person accountable for the delivery of our shared plan and outcomes, who is agreed with the local authority, with providers and with the Integrated Care Board. So it will be interesting to see what happens post consultation with that expectation. So that responsibility will be for commissioning and delivery of health and care services at place level, and local leaders are intended to set and agree shared outcomes and be accountable for the delivery. So quite a high set of expectations for that accountable leader at place level. In terms of what's the infrastructure to develop and deliver that better integrated care, the document talks about both pooling and aligning resources and trying to create simpler and less bureaucratic systems for having these pooling arrangements. So it talks about things like moving beyond Section 75s, which is one of our predominant mechanisms for pooled funding arrangements. It is saying that there will be a new policy framework for the Better Care Fund. And I think one of the expectations is that some of the approaches that have been used for the Better Care Fund, the setting of a kind of collective set of outcomes to be achieved through that pooled fund might get expanded into other sets of outcomes in other areas. So the legislation covering pooled budgets will be reviewed. There will need to be some reform and relook at digital and data mechanisms for sharing information, because that is going to be such an enabler of future integration, and there will be a data strategy. And greater digitalisation, which has a big focus through the white paper. Thank you. So I think the other points to mention from this is that one of the factors that can either extend or hinder integration is the regulatory framework. So I think within Haringey we've seen, for example, through the SEND reform, that it required and expected a significant amount of integration in our services as a kind of precondition for that review. And I think there is an ambition to model that type of joint, more area-based regulation and inspection more broadly, although there is not a lot of further detail about that. The government is going to improve integrated workforce planning at place level, so we can expect some strengthened guidance for systems and more co-production, particularly with social care stakeholders. So there's a real recognition that at the moment it's very difficult to do that integrated workforce planning, and that there is a real need for that to happen at place level. There is mention of equal value and training and learning for staff who straddle that boundary between health and social care, and a stronger, more collective approach to promoting careers in health and social care, which mirrors many of the conversations that we've been having. There isn't, and I think we've recognised this, that the white paper doesn't do anything that is particularly signalling an intent to equalise pay disparity between health and social care. So it's very much more around joint workforce planning. So it sets the aspiration, but some of the barriers will remain. And I think I won't read out all of the others because I think that it's many of the same points, just about that sort of aspiration for workforce integration at place level, which to me was not quite as didn't have as many levers as I think it needs to have, but at least sets expectations.
Great, so I quickly wanted to touch on the third bit of policy that we wanted to highlight, which are the adult social care reforms set out in the Building Back Better white paper. And the based around 3 objectives. People have the choice, control and support to live independent lives, which may sound quite familiar. It's people who've been involved in social care over many years. People have access to quality and tailored care and support, and people find adult social care fair and accessible. It's fair to say that much of the discussion about these reforms nationally is focused on the sort of funding picture. It's really important that there's other elements around the importance of digitisation, for example, the skills framework for the care sector, and more support for unpaid carers. And I think it's really interesting that that comes through as a really strong theme, and in fact the funding for local authorities to be more innovative in the care that they're working on. There's already some work by DHSC on what those funding mechanisms might be to support innovation, particularly for unpaid care. So, as I mentioned, these proposals are backed by some thinking about funding. So the first is that health and social care levy, which in time will pass funding across the adult social care once the obviously once the backlog in the NHS has been completely resolved and we have no issues there. But we've got some challenges there about the sort of timing of that, and that this change in the way that client contributions, particularly around residential and nursing care, are funded, means that there's a more generous means-tested approach than previously. It also means that there'll be changes to the whole market, because the way that self-funders operate at the moment, it's sort of set out quite clearly in the white paper that actually self-funders have been subsidising some of the care available, and actually this will come to an end when the top rate, the cap is in place. So just to mention then that there was wider supports to the social care system that I mentioned earlier around unpaid carers and the assurance framework, really strong focus on workforce, which is that theme that cuts across the three policy pieces, and nice to see a disabled facilities grant funding increase in there as well. The second key fund is around integration of health and social care. So again, that strong theme running throughout these policy reforms, about greater autonomy at local level, about really joining up around place. And then, as I mentioned, the third element is around this sort of funding mechanism. So that's a quick whiz through. We wanted to share that because it feels like it's really important to our work going forward that we understand the wider context we're operating in. As I say, take some comfort that there is some consistency and coherence in the thinking. There are some tensions, clearly with the pull on potentially on ICS for the health and care bill, the pull towards place and the integration white paper, but they're sort of, I think, lively tensions and ones that we can work over.
Thank you very much, and thanks to everyone for all your hard work, really. It is a journey that we're on and we're navigating it, but I think the one thing that we are doing is we are working together in partnership, and we are working closely and moving on together on that journey. So I think that in itself is a really positive thing. So the credit to everyone here. So thank you very much for that. I'm going to move us on to the next item, if that's okay. And I believe it might be you again, Charlotte. With Jeffrey on racism and inequalities.
Thank you. I just wanted to share quickly some slides, which really, in generally, what we've done here is to we'll circulate these with our sort of updates, but what we've done this time is just put on the first two slides the things that we feel are making the most progress at the moment over the time. So the first is a particular focus on supporting the Somali community in the Borough. So we've had our first formal meeting of the Somali Community Network at the end of last month. It was a really powerful discussion and really positive ways of working together, which I think will be a sort of formula, as it were, for us moving forward. And to sort of promote the session at the end of March in Marcus Derby Library on early years and early health provision, which is really a sort of bit of opportunity for those communities to access directly early years information and early health information, and follows the sort of housing surgery that took place at the end of last year, which was so well attended that we're having to run another one. But it's also, I think, really been a helpful sort of, I guess, sort of, I don't know quite what the word, I was going to say wake up call, but I think that's probably not quite fair, but to housing services about the level of unmet need in the local community, because people feel that they can't communicate and they're not getting through to the housing services. The third, Councillor Upton mentioned earlier the work underway to support Ukrainian refugees. I'm attending a briefing tomorrow as well on the latest position, hoping that the more detailed Home Office guidance is now out for Ukrainian refugees. We've had a first meeting of our sort of local Ukrainian support network. I'm really hoping that will develop into a much broader set of support arrangements for across our Eastern European communities in the borough. Really important that it's we recognise this. I mean, obviously there could be a huge number of households coming into the borough. I think I'm not aware of the numbers of local residents who have volunteered under this sort of community sponsor scheme or local sponsor scheme. But I know on BBC London last night they were sort of focusing on particular communities, and some really nice stories about people offering their spare rooms and just a show in their houses. We had our first diversity in the public realm meeting yesterday, which was an exploratory meeting to really think about how we start conversations with our wider communities in the context of thinking about identity, about how we connect with our local borough. It rose out to some of the work on street names, on how people recognise themselves, but we agreed that we wanted this to be a broad conversation about really celebrating the amazing diversity that is Haringey in all its glory. So picking up issues around ethnicity, but also around disability, around abuse and age, around sexuality, and making sure that the borough feels safe and welcoming and celebratory of all the diversity that Haringey has. The Welcome Advisory Board is overseeing and working with faith groups in Oswald Hill, a promotion of a sort of a local welcomes model. So just working out whether we could extend that, for example, into the east of the borough. And then the Health and Equalities Fund, which has a particular resonance with this ward, as it's come through the NHS route, is really picking up pace and developing services really led by local voluntary community organisations at the grassroots. So those are the areas we wanted to highlight. The rest is probably by way of update what you can say to make the slides. Right.
Thank you. Thank you for whizzing through that. That's amazing. And we are doing some really, really important work. And I've had a little bit of feedback in the community that noticing that work as well. So I think that's a credit to everyone. Thank you. I don't know if anyone else has got any points or comments. Jeffrey.
Thanks, Charlotte, for the update. Thanks, Chair. Charlotte, there's a lot of speculation in the chat where you're speaking from, but I won't go into that here. So you can look it up yourself. Otherwise, just to add on to what Charlotte says, I'm not sure where we trailed this before, but I think you're all aware of the kind of racial inequalities focus that needs to happen, or indeed a forum that we need to create, which builds up on the NHS Race Observatory report, but also I think some of the stuff you were saying there, Rachel, around the HealthyNet data as well. We're now looking for the kind of, is not meant to be a kind of oversight or anything like that, but I think an helpful forum or mechanism whereby we can all come together and perhaps have a bit of a drive or a focus, I think, in terms of trying to keep the momentum going in this particular area. So I think the first meeting we're trying to look at is probably going to be sometime in June now, because of all sorts of stuff. Just for information, Chair. Thank you.
Thanks. Thank you, Jeffrey. And really thanks for all this work, because we know how important it is to our community and to the outcomes that we want to see. So thank you. So I'm going to move us on. I'm going to ask Will to give us a vaccine update in one line, because I know we're going to come back to this topic at the next meeting. So
yeah,
tell us in one line, Will.
Can't do it in one line. I'll try 60 seconds. I'm Will, Director of Public Health in Haringey, just giving a brief update on COVID. So COVID rates have fallen in the borough significantly since the sort of December, January peak of Omicron. But just in the last 2 or 3 weeks, they've risen slightly again, but nowhere near the numbers that we were at before. And this has mainly been in the sort of working age adult population. We're not seeing this as schools phases seems to have ended. We're not seeing lots of cases in schools. And I know actually that a lot of us know people who've been affected with COVID. The good news on the Omicron variant is it is less severe. Vaccination also gives us protection. So while we saw high case rates over the last few months, we haven't seen that significant increase in the number of people getting seriously ill, and the hospital admissions remain stable. This has allowed the government to move into this kind of living with COVID phase, which basically is withdrawing all of the kind of supports and funding that local authorities had for things like testing. There'll be no requirement to test apart from for certain sectors like health and social care after 1st of April. So it really is a very different landscape, one around very much focused on kind of personal responsibility, looking out for yourself and symptoms and isolating when you're feeling unwell. Vaccination remains a really key part of the programme nationally and locally. So there will be a 4th vaccination for over 75s and people who are clinically vulnerable. There's already been a 4th vaccination offer for people in very high sort of clinical vulnerability groups. That will happen from April onwards and will be provided locally in a number of different settings as before. There'll also be the evergreen offer and an offer for 5 to 11-year-olds, which won't be delivered in schools, will be delivered in the community from April. So we'll still be doing lots of comms and engagement. We've still got our vaccine bus going out for April and May as well. It's been a real team effort, and we'll continue to do that work around vaccinations. But we are moving into a very much a different landscape, notwithstanding the discussions we've had earlier about things like long COVID, which are still really significant. And then we'll need to look at again review our response as we go into autumn and winter next year.
Thank you, Will. That was brilliant. That was a good enough flavour, and I know we'll come back to this topic. And so what I'm going to do is just move us on and flag up our well, there's 2 things to say. We've got a few things on the menu. Oh, Sharon wants to come in. Apologies, Sharon, come in.
Yeah, sorry. I think it's an important question. I mean, how confident are we that we know about the current trends in COVID? Because certainly I know a lot of people that have contracted it in the last couple of weeks, and I think most of them wouldn't necessarily have registered the fact that they've tested positive. I mean, how do we know? How are we tracking these trends?
Yeah, so fortunately we do still have PCR testing. It's going to be a different picture post April. We've also got the Office of National Statistics survey, which is really powerful because that does give us a proper prevalence indicator for the different regions of the UK and the different age groups, and that does show that the prevalence is going up in London, particularly in the older age groups. There will be surveillance systems as we go forward, and we'll have to link into those. But yeah, we won't have, as we've discussed before, Sharon, we won't have the level of detail that we have at the moment in terms of testing. But there will be surveillance systems in place, as there are for other infectious diseases at present, like influenza. So we do still have a picture of what's going on, but just not to the level of detail that we've got at the moment.
Isn't there a time lag with those other systems, like the national survey thing? Doesn't that take a while before we find out whether there'd been if there were a surge in the last couple of weeks? When would we know that there'd been that surge?
You're right. There is a time lag on the ONS data. So we've still got the local testing data. There'll still be testing in health and care services, which is really important. So if people go into health and care services with COVID symptoms, so if we really saw a significant spike, we would pick it up in that route. The other way we pick up other infectious diseases is in the kind of classic way. So if we had a number of people getting ill in a school or a care home, we would then go in and do testing and pick it up that way. And we've always classically kind of responded to public health outbreaks with Public Health England, what's now called UK Health Security Agency. But yeah, I do hear your concern, Sharon, and happy to kind of once we understand what the new system is looking like, happy to come back and give an update.
I think people are asking these questions now that we've moved into this new phase as to who's in charge, who knows what, and what is there this new surge that we're expected to ignore? I think that those are questions that people are asking as this thing
Yeah,
moves.
I certainly say that the levels we're seeing at the moment from the data we have, things like positivity rates, other things we can measure, it's not a surge like we saw in January and February. It's a small increase, and for example in schools we're just not seeing the number of cases we saw early, and we still got good testing in schools. But you're right to raise those concerns.
And what about the link between the Omicron and long COVID, or is long COVID associated with the pre-Omicron infections?
Yeah, so we don't that question is not definitively answered yet. The early suggestions are it's the risks of long COVID are much lower with Omicron, and the vaccination gives you significant protection against long COVID.
Okay, thank you.
Yeah, I think that's right, isn't it? It's a little bit of an open one as yet. I think they're really valid and good questions. Thanks for asking them, Sharon. You know, and I'd hate to be political and say, we'd all like to know who's in control and who's in charge. And those of us who are in this call who've all experienced COVID lately, we might have certain perspectives on that. Beverly, I'm going to bring you in, and then I'm going to wrap us up fairly soon.
Yeah, just really quickly, Will, I wondered if you could just comment on what we're seeing overseas. China now, this sort of massive surge again. America, some parts of America, a massive surge. What are we to learn from that? And how does it impact on our response here?
Yeah, so my take on that is that every country in the world now, because of Omicron, is kind of lifting restrictions and relaxing. And in Britain, we've got these, because we've been affected so badly, we've got quite high levels of either natural immunity or vaccine protection, whereas in other countries, they haven't got. So in China, they've been really good at suppressing the outbreak, but because Omicron is milder, we've seen in Australia, New Zealand, they're lifting restrictions, and they're seeing really significant rises where they have unvaccinated populations. But there is something that we need to understand around kind of recurrence of infection, how quickly that can happen. We are going to see, repeated, probably we might have to get used to having these kind of waves of COVID, hopefully with milder strains like Omicron on a regular basis. So we are likely to see increases again, and we're just kind of relying on the vaccination program and the fact that the severity is much lower, and we're treating it more like flu now, because in effect the severity data is quite similar to influenza with Omicron, although it is still a different infection. So I'm reluctant to make that comparison.
Thanks.
Thank you. Thanks, Will. I think sadly it does seem likely that we will continue to see a growth in things like long COVID, even no matter how small. Although I know there's a lot of discussion amongst the scientific community about that. But nevertheless, I know we're going to come back to this. And the last item today is just discussing a few agenda items that might be coming up in the future. And we've already talked about long COVID and the Health Watch report. We've also got here as a suggestion the Better Care Fund plan, child and adolescents mental health services that came up today, and the draft health and wellbeing strategy, a bit more on ICS, and estates and workforce. Those are some of the items that have certainly been on my mind. I'd also suggest that we should talk about dental care at some point, because it's a really hot topic. Sorry, that's the wrong expression. It's a really significant issue for our residents, and I'm getting a lot of reports about people unable to access it or only at exorbitant costs, which obviously has a huge impact when we're talking about our disparities. Will and Charlotte, do you want to come in?
Yeah, thanks, Councillor Desnev. So the two items I was going to flag for the future. So the first one was dentistry, where we've made some inquiries actually across North Central London. This seems to be an issue, and the commissioning of this is through NHS England. So we need to look at kind of both a local and an ICS response, that's not just in Haringey where that's an issue. And then the second one is something called the pharmaceutical needs assessment, which we have to do every few years, and is quite a systematic process. It doesn't often lead to really significant changes in pharmacy provision, but it just maps out where our pharmacies are and the kind of services provided, and there have been surveys on that, and we need to bring that to the Health and Wellbeing Board at some point. We don't bring the finished document. We normally bring a kind of information sheet and then delegate that decision to myself as Director of Public Health to sign off. So not the most strategic thing, but one to highlight for the future.
Thanks, Will. That's very helpful, Charlotte.
Thank you. I guess the other areas that we've talked a bit and we touched on this morning is localities, bringing an update back through this board. And then the second was the following on from the NEAM work, the Making Every Adult Matter. We've been working on a sort of vulnerable adults approach, which picks up that sort of wider response to people's complexes and not touch the statutory services that are very, very vulnerable often. So I wanted to bring that to the Health and Wellbeing Board for the future too.
Thank you. Thanks for that, Charlotte. So there's plenty more work to do, clearly, and a lot of meaty topics for us to do for Health and Wellbeing Board to discuss. And I see Jeffrey's put in the chat the Farm Assessable Needs Assessment came to CCG engagement meeting last week. Thank you for that. So I'm conscious of time. We do need to wrap up. This is my last meeting of this administration. So I just wanted to thank you all very much for your engagement, your hard work, and for your patience with the chair and cabinet member too. So thank you all very personally for all that you're doing and all that you will continue to do. Charlotte, you've got your hand up.
Oh, sorry, I would like to
Right. Thank you. And onwards, as they say. Have a good afternoon.
Thank you. Bye, everyone.
Bye. Bye-bye.
Bye, everybody.
Thank you. Bye.
Bye-bye.
Government elections, really serving on guarantee. Yeah, she's actually selection.
Oh, has she?